Good evening, Doctor. I, Shuman, on behalf of Shield Healthcare, welcoming you. And the topic of the today's webinar is Dr. Rajendra Kumar, Dr. Rekha Rajendrakumar, madam. And before moving to Connect page, this is your
Sir, there is some disturbance, sir.
blog. Sorry, there is some internet issue. Let me share one thing. So here you can find different blogs written by many eminent doctors across India, and these are the past webinars tab. Here you can find all the related topics already we have covered in our previous webinars as well. And this is the most important thing in this COVID era period, that is respiratory immunity blog. Here you can find different topics on our respiratory immunity. And this is the PCOS awareness blog, you means webinar tab, and you will find different talk by eminent doctors in different regional language, as well as you can see that Hindi, English, Malayalam, Kannada, and many other languages too. And the most important thing is our key opinion leaders, and almost across 250 to 300 doctors are currently supporting us in this knowledge sharing initiative from Shield. And I request all the participants to please look into this website, as it's a very important and informative one. And now it's time to start our webinar, and it is my pleasure to introduce Madam. Although Madam doesn't require any kind of introduction, but I'm just briefing few of it. Madam did her MBBS, MD DNB, FICOG, FICMCH, PGTMLE, and fellow reproductive medicine. Madam is currently the medical director, Miracle IVF Hospital and Chandana Hospital, Bangalore. Madam has many awards to her credit. She is All India topper ICOG reproductive medicine examination, first rank in MD University exam, 7th rank in Bangalore University MBBS exam, and 11 awards and 3 facilitation, including 3 state awards as well. Also, Madam is holding some few positions, including practicing gynecologist for the past 30 years, honorary secretary BSOG 2020-21, chairperson infertility and ART committee KSOGA 2020 to 22, chairperson infertility and ART joint organizing secretary of Avigyan 2021 Foxy FIGO SAFO BSOG International Conference. Also, Madam is the member of Foxy Infertility Committee, Sexual Medicine Committee, Endocrinology Committee, Food and Drugs Committee, ex-PG teacher of MS Ramaiah Medical College, Bangalore, Pubsit Hospital. Madam is the speaker, chairperson, moderator, and panelist in more than 400 state, national, and international conferences. She is the founder of EC member, Indian Fertility Society, Karnataka chapter 2019 to 2023. Madam is the Foxy Maniata certified state level lead assessor for obstetric standards of hospitals. She is a live member of BSOG Foxy, KISAR, ISAR, IAG, PCOS Society of India, IFS, Karnataka Cancer Society, NARCHI, and is the committee member of Infertility Workshop and a reviewer and judge of many poster and paper presentation committee of the ICOG 2019. And apart from that, Madam has many papers and publications in many national and international journals of well repute as well. So with the short introduction, I hand over the session to ma'am. And I request all the participants for their active participation, and please put your queries on the QA dashboard of the Shield Connect platform. So after finishing of the talk, so we can have a short discussion on this topic with ma'am. So thank you, madam. Thank you very much. And over to you, ma'am.
I'll just share my screen. Yeah, thank you, Dr. Suman Saha. Thank you, Shield Pharma, as well as Mr. Krishna Patil of Shield Pharma for giving me this opportunity to talk on today's topic that has been quite relevant, though it's spoken many times. That's on recurrent pregnancy loss. Am I audible, Dr. Suman?
Yes, ma'am. You are audible.
Fine. All right. Thank you so much. Thank you. So today I'm going to talk about recurrent pregnancy loss and its management. Let us know what it is for us. It is a very enigmatic disease. Like we say for endometriosis, even recurrent pregnancy loss has lot of confusions about starting right from the diagnosis till treatment. And sometimes in spite of that, we are left with no option available and patient coming back to us with pregnancy loss. So, when we carry a life and it is there inside that body for some time and then it is gone, a part of your soul dies. That is what the mother feels. And this is what Cassie Vigano says. So, why are we so much bothered about RPL, that is recurrent pregnancy loss? Because one, it is not only the problem of the patient, that is the woman and her husband, it beholds lot of problems inside that. The agony is unbearable for the family, especially if it is recurrent. One loss itself is too much for them, but when it is a recurrent problem that it keeps happening again and again, that becomes a very big problem for her. It's not only a physical condition, it involves so many other problems. It is one of the important social problem also, because it is not just the health of the mother like the diabetes or hypertension where the problem is per se of the patient. It is not just that. There is a lot of social, psychological and spiritual domain of health. Example, the social problem is the whole family will be waiting to invite a new guest into their family. The pregnancy is confirmed, the beta HCG or the urine pregnancy test has come positive. The family has lot of plans in the line for that new arrival, and the problem happens and all their dream castle is shattered. It is difficult to diagnose. The RPL is very difficult. Recurrent pregnancy loss, it keeps happening. You don't know, as a doctor, as a specialist, you don't know why it happens, because the etiology has lot many things under that. There are quite many number of speculations regarding the diagnosis, and it's a manifold problem. Again, diagnosis difficult. It is difficult to treat also, as no exact cause is identified. I have never come to the exact decision of the cause. Where will I know the treatment part of it? So there is no perfect treatment because the cause is not known. There is no guarantee that problem will not repeat because the diagnosis someday is disturbing. Can they all be muted, please? The problem is so that difficulty in diagnosis, difficulty in definition, difficulty in the treatment, at every part there is uncertainty. There is lot of cost involved, especially if it is ART pregnancy. Even otherwise there is lot of cost involved because the diagnosis of pregnancy is made and
find different blogs written by very eminent doctors
excuse me,
and these are the first webinars there. Here
excuse me, Mr. Suman, Dr. Suman.
Already we have covered in our previous webinars as well. And this is the most important thing.
Dr. Suman.
Period that is respiratory immunity block. Here you can find different topics on our respiratory immunity.
Dr. Suman.
Ma'am, I will inform him, ma'am. I will inform him.
Webinar tab, and you will find different.
I'm telling to patients.
Can I proceed? Can I proceed?
Ma'am, now you can continue, ma'am.
Yeah, but somebody is continuously talking and making lot of noise. Must be Dr. Suman. Please tell him to mute. Talking, shield training, that person is talking. All right, fine. It is difficult to treat, as I've already mentioned, and there is no guarantee that the problem will not repeat because of all the problems which I've already mentioned. Lot of cost is involved, whether it is an ART pregnancy or not, because the doctor wants to be more safe and more sure that we are not going to lose this pregnancy. So takes extra precautions, extra tests, extra visits, extra ultrasound scans, and there are more number of drugs that are involved. So the cost, the affair is going to be a costly one, especially if it is ART pregnancy. That too, the combination of this pregnancy happening because of ART with the previous history of recurrent pregnancy loss, definitely the cost is going to be much more and gets escalated. It is difficult to obtain the statistics, and hence it is difficult to assess the magnitude of problem. Exactly, because certain kind of these recurrent pregnancy losses do happen before the proper diagnosis is made. In the sense, the woman might have lost that pregnancy at home before she gets even the urine test for pregnancy done, or even the beta HCG done. The woman, or say biochemical pregnancies, she may lose it very early stage. So I really don't know whether she was pregnant or it was just an amenorrhea. So because of all these problems, sometimes the diagnosis is not made of, so hence the statistics is very difficult to diagnose. Somebody is continuously talking. Please, please.
Please,
You can mute as the one who is managing the
please,
show, the
please,
host.
Chitra Allegation, madam. Please mute yourself.
Thank you. Now, let me discuss about this big problem of RPL under many headings. Definition, incidence, etiology. I tried to make it simple one because the topic itself is very complicated and very confused one. Coming to the definition, don't worry about the slide because the slide shows is, I just put this slide to show how confusing the diagnosis, the definition of RPL is. So many trials, and each trial has given each definition. I'm sorry. So don't go by the slide. Now coming to the big bodies like RCOG, ISHRE, among them itself, there is a lot of confusion. Among them itself, there is a lot of difference of opinion. What do they say? Royal College says it's loss of 3 or more consecutive losses. It has to be 3 and it has to be consecutive losses, one after another. Whereas the ISHRE differs from that. What does ISHRE say? The European Society of Human Reproduction and Embryology says ectopics, molar pregnancy, implantation failure, which are not very definite traditional pregnancies, in the sense those pregnancies which are not sitting inside the intrauterine cavity should not be included in the definition. They say these are though pregnancies cannot be under the category of RPL. They also say the ISHRE goes one step ahead and it says that terms like spontaneous abortion, chemical pregnancy and blighted ovum are ambiguous according to ISHRE, and they also should be avoided. This is what ISHRE says. BMJ, British Medical Journal, says it's a simple definition that it is only 2 or more losses. Need not be 3, nor it need not be more losses like consecutive losses or not. It is immaterial. That's what BMJ says. American Society of Reproductive Medicine says it is loss of 2 or more and they need not be consecutive, unlike RCOG. The ACOG, American College of Obstetrics and Gynecology, says loss of 3 or more consecutive losses, but need not be intrauterine. Look at the confusion there between themselves. The WHO has come to a different version of the definition. WHO says it goes just by the weight of the fetus. That is probably the age or the weight by which the baby is going to be, the fetus is going to be viable, and that puts the watershed line at 500 grams. So, but making a consolidated definition so that none of us get confused about all this, and remembering all these definitions are big tasks. So it is a simpler diagnosis and a consolidated definition that is made is, it is a spontaneous loss of 2 or more intrauterine pregnancies. I have just underlined the important words there. So it is a spontaneous loss. It's an intrauterine pregnancy. That means ectopics, etc. are ruled out, and before 24 weeks. So this is the latest definition, probably from 2013 onwards, because before 2013 we had put the line, that is the demarcation, at 20 weeks as viability. Now 24 weeks, up to 24 weeks, it has been, the line has been drawn. So before 24 weeks, so another 4 weeks extra. So before 20 weeks, 24 weeks of gestation, that is before viability, irrespective of mode of diagnosis, whether you have done by a clinical examination, putting your Doppler stethoscope there, or whether you have done by an ultrasound diagnosis, however you have diagnosed, irrespective of the diagnosis, it has to be the combination of spontaneous, intrauterine before 24 weeks. This is what is the definition. Under this, there are some categories, or I can call it as classification. The early RPL is less than 12 weeks, that is the first trimester. Late one is, that is the secondary RPL or the late RPL, like say cervical incompetence or the uterine anomalies where the pregnancy happens. Probably the later one is 12 to 24 weeks, that is the second trimester. This is another classification of RPL where it says primary, secondary and tertiary RPL. This is not in vogue to a very great extent, but it says primary RPL is the one where the woman has never had a previous viable infant, that is, she has never crossed 24 weeks of pregnancy. There is a secondary RPL is a bit different. What does it say? It says women with the previous history of delivery beyond 20 weeks. This is latest definition is 24 weeks rather, and then suffered the subsequent losses. She has had one pregnancy more than the period of viability, and then she has lost the next pregnancies. The tertiary one is again bit different. It says it is to those women who had multiple miscarriages in between few normal pregnancy. The first one is normal, quite healthy baby at home. Third one is again fine, whereas she lost a pregnancy in between. Certain kinds of those pregnancies are categorized under tertiary RPL. Please excuse me for this big slide of statistics. You can take whichever lines relevant to you or whichever are appealing to you, but I thought there are certain important factors here just to emphasize on the burden of RPL. If the woman's age is less than 35 years, the incidence or the burden of abortion is 9 to 12%. If a woman's age is more than 40, it increases, it leaps by more than 50%. She is not at all sure of taking baby home, in the sense out of 2 women who conceive more than 40, one is definitely going to lose her pregnancy. It is amounting to more than 50%. 15 to 20% of all pregnancies are lost, whether we as clinicians, as primary physicians, as healthcare professionals do come to know or not. For that matter, even the woman may not even sometimes know that she's pregnant, but those pregnancies are lost, and out of that 90% are in the first trimester. 10 to 20% of the pregnancies are the very first pregnancy is lost, that is 1 in 5. 10 to 20% of the women have one sporadic spontaneous abortion. 5% have 2 spontaneous abortions. Out of that, 2% have the 2 consecutive spontaneous abortions, one after another one very immediately, and the 3 consecutive spontaneous abortion can happen in up to 1% of women. 13 to 17% is a chance of recurrence after first abortion. 35% chance after 2 abortions. It has increased, it is doubled. Look at that. And 45 to 50%, again, it increases by about 30-40% if she has already had 2 abortions. That means it's around 50% after 3 abortions. Spontaneous successful pregnancy after 2 miscarriages is 60%. Ultimately, look at that. The bottommost line is encouraging. So there is silver line at the end of dark clouds. So what it says is that the woman, when we counsel her, when she comes to us with the fear that she has already had 2 miscarriages, she will ask us, doctor, I had 2 miscarriages already. What about this pregnancy? Do I stand any chance? Yes, of course, dear woman, you do stand a chance. That is, it's a very bright chance, not just the chance. It is about 60% there is chance of you having a normal pregnancy. So you can as well continue and we will manage. This is what I'm going to tell her. This is just a summary slide where it says, look at that. The maternal age, when it is around 12 to 19%, that 12 to 19 years, I'm sorry, such a young girl, her chances of spontaneous abortion, though it is such young age, that stands around 13%. When the woman's age is more than 45, Anderson says it was a 2000 year 2000 way back study, but he says that is 93%, though in our practice we do not get that percent, maybe around 50 to 60% of the pregnancies are lost when the woman is near 50. So the chances of the stillbirth also when the woman is young is only 5 out of 1,000, whereas when it is more than chances of stillbirth also increase. This is what the slide says. Coming to the etiology, I have just finished the big confusion of definition. I'm talking about the etiology here. Again, I have categorized under anatomical causes, that is the structural causes inside the uterus, whether it is an acquired or inherent problems. The genetic factor, here look at this, the immunological and thrombophilia I have put together convenient that you are not confused, because ultimately the pathology is thrombosis and the treatment is also same. So for I have put this under one category. Coming to the endocrine factors, there are a lot of endocrine factors which I am going to enumerate in my future slides. Of course, don't neglect the male. That is what this says. The male factors also have a strong weightage, strong bearing, strong impact in causation of RPL. Infections, certain kind of infections are notorious in causing RPL, whether it's a male or female, and let us talk about miscellaneous causes in future slides. So only in 50% of the cases, the cause can be explained. Whatever list I have mentioned up to infections explains only 50% of the RPL. 50% are always unexplained, and it's very difficult to understand the cause. It is important to emphasize to patients with unexplained RPL that the chance for a future successful pregnancy is up to 50 to 60% depending on maternal age. So she need not be discouraged. There is always light at the end of the tunnel. Now, coming to the anatomical uterine factors, all of us know this is just to mention. I have put a summary of the different diagnoses, that is the anatomical diagnosis. Submucous myoma, as all of us know, even bigger intramural myomas can cause problems. More than 4-5 centimeters of myomas being intramural, not even touching the endometrium, not compromising the endometrial cavity, blood flow can cause problems because of various reasons which I am not going to enumerate. Intrauterine polyp can cause problems, usually less than 1 centimeter. But when the woman has had a diagnosis of RPL and the ultrasound TVS shows the presence of polyp, it's my duty to remove this polyp by hysteroscopy. Subseptate uterus, as all of you have found in your practice, encountered, can cause the problems like bicornuate, unicornuate, or didelphic uterus. These are fusion anomalies of the uterus. Synecdoche, maybe because of the infection, maybe because of the repeated curettage, maybe because of unnoticed incomplete abortion, etc., can cause the problem inside the uterine cavity, compromise the vascularity, thus resulting in RPL. Cervical incompetence most of the times causes second trimester abortions, where the cervical musculature, especially at the internal os and the cervical canal, is not so tight. It can cause problem. Chronic endometritis, whether it has caused addition, synecdoche or not, maybe a bald endometrium where the blood supply of the subendometrial and the endometrial layer is in jeopardy and can cause a problem in blood supply. So how do they affect? That is, the anatomical problems, how are they going to cause RPL? It can cause problem because of all these reasons. Smaller or distorted uterine cavity, maybe like uterine unicornuate uterus, the fewer suitable implantation sites, maybe like a submucous myoma where the vascularity on that is not so good, or maybe the septum complete, incomplete, subseptate uterus, etc. Compromised vascularity, maybe like the synecdoche, like Usherman's, and cervical incompetence. It is not the vascularity as such here. The problem is it can't hold the pregnancy. The musculature of the cervix is so weak that it gives way, and thus the pregnancy gets expelled. This is a slide which shows causes in nutshell. Just note this point and that's enough, and don't get confused in this slide. Just I want to reiterate the fact here that is the most common cause. Look at that. It's around 55% out of the total uterine anomalies. The uterine septum, I'm not talking about the whether RPL. I'm just talking about the total number of uterine anomalies, and out of that, when you categorize, the septum is around 55% of the case. That unicornuate is around 20, didelphys is still less common, bicornuate is 10%. What I want to emphasize the fact here is the uterine septum causes the problems in 25% in the early abortion, and late abortions are less common. That is the implantation problem, and even if it gets implanted, the early trimester abortions are much more common, because I have already explained the fact, like that is there is a compromise in the vascularity. Nourishing of that embryo itself is at stake, and because of this, that woman loses her pregnancy in the early part of her pregnancy journey. Unlike the bicornuate uterus or unicornuate uterus, where usually the vascularity is not a problem, it is the capacity of the uterus to hold the pregnancy. Rooming of the uterine cavity is a problem, where the early abortion, it is a reversal of this fact of uterine septum. What I want to say is unicornuate uterus, the early abortions are less. The pregnancy is small, the volume of pregnancy is small, and that can be easily contained in this unicornuate uterus. But the pregnancy grows, the volume of pregnancy increases, and the room is not big enough to hold that pregnancy, and thus the chances of late abortion and preterm labor is up to 30%, similar to the bicornuate uterus or the uterus didelphys. This is what I want to say. The uterine septum, all of us know it, since it is a slide in nutshell. I just want to say that the corrective methods also here, the hysteroscopic removal, all of us know it's not the removal, it's just cutting of the septum so that it gets separated. There should be no loss of tissue, as all of you know. The unicornuate, the cervical encerclage, many of us do when it is unicornuate uterus, the rudimentary horn to be excised, if at all it is there, and it is not connecting, or either connecting or not connecting, not big enough to hold the pregnancy, because it can cause problems like dysmenorrhea, hematometra, ectopic, etc. Lateral metroplasty is not so popular because it is not that rewarding. Didelphic uterus, once upon a time when we were students around 20-30 years back, probably 2-3 decades, the Strassman's operation was very popular, but that has taken backseat now, and we are not operating, Strassman's operation is not being done. It's only the cervical encerclage at the maximum. Similarly, in bicornuate uterus, the cervical cerclage is the only thing, that is the only treatment, surgical treatment that is given. Strassman's operations like unification, etc., are not indicated, have become obsolete. Coming to the genetic causes, I've just finished the anatomical causes, just talking about the genetic causes. I've just put some practical tips here in all my slides probably. The fetal karyotyping, I'm not talking about the paternal or the maternal karyotyping. I'm talking in this slide about the fetal karyotyping. That can be any of these, and these are the most common abnormalities, that's a chromosomal aberrations that are found, that is trisomy, monosomy X, polyploidy, and translocations. Very difficult to diagnose translocations. It is recommended after third miscarriage. Patients do come, they go through the internet, the Google uncle tells them that after first miscarriage, second miscarriage, or sometimes they talk to their friends and they say, doctor, I have lost this pregnancy, can you save my second pregnancy? What happened to the first pregnancy? Did you check it for the karyotyping? Should you send the products of conception for testing, etc., etc.? etc. But according to the many trials and studies, they have told that the recommendation is only after the third miscarriage, not routinely recommended after one or two abortions. Don't forget about the sperm problems also. It is not the maternal problems always. The sperm aneuploidy directly influences the rate of aneuploidy in the conceptus. So the male factor is also equally responsible. So I land in parental karyotyping. The incidence of abnormality in general population is very small, less than 1%, but that gets hiked to almost 10% increase in couples who had RPL before. So look at that, it's almost increased by 10%. The peripheral karyotyping analysis of the parents is recommended. It is just the blood test what we do, unlike testing of products of conception. This is the blood test, and that is recommended only if the product, there is again some difference of opinion between the green top guidelines, that is the RCOG guidelines, and the ASRM guidelines. What does RCOG say? RCOG says send products of conception if the send the parents for peripheral karyotyping if only the product of conception reveals unbalanced numerical defects. Whereas the ASRM says it should be done in all cases of RPL, irrespective of all these unbalanced numerical defects, etc. Like even if the POC is normal, you send the parents for the karyotyping. When it is more than more than 3, I'm sorry. Carrier or balanced chromosomal abnormalities are very common, and its incidence in anembryonic pregnancies is almost 90%. If maternal age is more than 40, chances of chromosomal aberration is also linearly increased, and that is more than 40%. Now, we keep telling this term translocation. What does translocation mean? Translocation is just the exchange of chromosomal segments. It's a balanced translocation rather between two homologous chromosomes. This is chromosome 1 and this is just I'm numbering them. This is the chromosome 2. What happened here? The G and H, that is the gene pattern, got exchanged. The G and H of the first one gets shifted to the second chromosome, and the Y and Z of the second one has come to the first one. This is an interchange of these materials between the two, and that is what is translocation. Now, this is a slide where the x-axis and y-axis show two things. It is the x-axis shows the maternal age and the y-axis shows the fertility rate. The fertility rate per 1,000 married women, and look at the maternal age here. After the age of say 30, 32, the fertility just falls like anything. It's almost nose diving. The fertility, there is a deep fall in the fertility, and this is the spontaneous abortion. Though they cross at around 39, 40 years of age, the woman has to be careful or awakened much before that. So the chances of spontaneous abortion is much more after the age of say around 30, 32. That increases so much exponentially, and this just falls so steeply. So the fertility falls, and in spite of that, if she gets pregnant, chances of spontaneous abortions are also equally rife. So this is the problem, and this does not apply only to RPL. This is a general slide which we have to tell all our women who walk into our clinic, where they say that we do not want to conceive now for whatever reason it is. And this problem is becoming very common nowadays because of late marriage, whatever. There are so many factors. Let us not enumerate on that. This is just to show that even the chances of RPL or the abortions are much more after the age of 30, 32. That's all I wanted to say here. Coming to the immunological causes, they cause thrombophilia. Ultimately, it is a hypercoagulable state or thrombosis that happens. The hereditary thrombophilia, that is the hematological causes, are the cause here. The acquired causes may be like the SLE or the APLA syndrome. Alloimmune causes, that is the conflict conflict or the battle or the mismatch between the mother, maternal response and the fetus. The hereditary thrombophilia, we do not check for all these, not so common, not so popular, not so friendly. Factor V Leiden mutation, protein C, S deficiency, antithrombin 3 prothrombin gene mutation. This is another important thing, that is the methyl tetrahydrofolate reductase enzyme gene mutation. Ultimately, that results in hyperhomocystinemia because the active form of folate is not formed. So the raw material or the homocysteine increases in the body. Homocysteine gets converted to folate through methionine cycle, vitamin B12. All of you know that the pyridoxine, so many things, but that does not happen. And ultimately, the homocysteine gets accumulated. Homocysteine is one of the important factor that is known for causing thrombosis in blood vessels. It need not be regarding pregnancy. Since we are the obstetrician gynecologist, we concentrate on pregnancy or RPL, but even other causes like stroke or the myocardial infarction, acute thrombosis in the epicardial blood vessels, all these are very common. Young boys dying at the age of 35 who has checked their homocysteine level, maybe because of that. So ultimately, they all cause thrombosis on the maternal side of the placenta, and that causes subsequently the fetal loss, IUGR, abruption, PIH, etc., because there is a hypoxia of the placenta on the maternal side. Coming to the autoimmune causes, this attributes to a very great extent. Look at that. It's around 10% of the RPL is because of the autoimmune cause. Two important ones out of the autoimmune, the two clinical entity which are quite familiar with us are, it is either the antiphospholipid antibody syndrome or systemic lupus erythematosus. About 10 to 20% of the women with RPL have antiphospholipid antibody. That's around 1 out of 5 women in RPL do test positive for antiphospholipid antibody. How do we test that? Let me enumerate in my future slides when I talk about the lab data. The major clinical criteria to diagnose APS. Now, since the APS is being related to RPL so many times, the Sapiro classification, the Sapiro done in 2006 has come to light. What does he say? According to Sapiro classification, the clinical data and lab data show different results, and so he has put it as the clinical criteria and the lab criteria. Coming to the clinical criteria under Sapiro's classification, it satisfies one, the vascular thrombus, either it's arterial, venous or small vessels, it is immaterial. Unexplained death of a normal fetus. Normal fetus matlab, it is not the genetic abnormality of the fetus. It was normal till 10 weeks and all the genetic problems usually gets ruled out. In the sense, if it's a genetic abnormality, most of the times it does not cross 10 weeks of gestational age. That's what he means. More than 2 consecutive abortions at less than 10 weeks. It's happened again and again. So the PIH or the placental insufficiency or vasculopathy, which happened much earlier, that is less than 34 weeks, and that made the obstetrician to terminate this pregnancy. So this is the clinical diagnosis, that is the clinical criteria which satisfies Sapiro classification. Let me talk about the lab criteria a little bit later. What are the endocrinological causes? Mild endocrine disorders are unlikely to cause RPL, like mild hypothyroidism, mild diabetes, mild PCOS, little bit here and there do not cause problem. Hypothyroidism, clinical or subclinical, that is in an overt case, say the TSH is 4, 5, that's not going to cause problem. Poorly controlled hyperthyroidism also can cause problem if not diagnosed earlier. Presence of thyroid antibodies, new entity that is taking attention now. When you say the woman is hypothyroid, the next question that is going to come from physician is, have you checked her thyroid antibodies? Okay, so presence of thyroid antibodies, even if euthyroid has shown slightly increased incidence of RPL, maybe because of the autoimmunity factor. luteal phase deficiency. Don't be surprised here when I say that out of total RPL cases, 35%, that's a big chunk of that, big contribution of that goes to the diagnosis of luteal phase deficiency. PCOS, polycystic ovarian syndrome, all of us know about the pathogenesis and etiology. That's hyperinsulinemia and hyperandrogenemia. Uncontrolled diabetes, of course, yes, if HbA1c is more than 9, 10, etc., she may lose her pregnancy. Male factors I cannot ignore here. Smoking, alcohol, job related like the scrotal hyperthermia, etc., can cause problems because that gives or emits abnormal sperms. Semen abnormality like the abnormal morphology of the sperm, coiled tails, double head, pinhead, so many things. All this can cause, they may fertilize, they may have a fertilizing capacity, but that embryo is not going to be fine. So the chances of the abnormal morphology, the presence of semen infection and decreased DFI, that is DNA fragmentation index more than 30% can cause RPL. The infections, Coxsackie-B and parvovirus are not so familiar, not so famous, probably anecdotal cases we hear, but the bacterial vaginosis is very common. It's around the corner most of the times. The chlamydia trachomatis, tuberculosis of the genital tract, and very, very common cause, another cause is urinary tract infection. The second part of this slide, please take attention here. Look at this slide. This says it's time to say goodbye to torch test. Most of the times we see the general practitioners or some practitioners doing the torch test, that is the toxoplasma gondii test, rubella, cytomegalo and herpes test for many of these women when they come with RPL. It's a strict no-no. Cochrane review has categorically proven that in multiple meta-analysis that none of the torch group of infection are responsible for RPL. Even in our FOXY guidelines, torch test is kept outside the battery of investigations because it does not throw any light, it just is a burden to the pocket of the woman and her husband. So take torch test out of your investigations. It will not give you any useful information. Coming to the miscellaneous causes, the occupational environmental factors like heavy metals, as all of us know, lead is one important notorious culprit here, organic solvents, mercury, and deficiency of micronutrients is getting some name and fame nowadays because they say a lot of micronutrients like chromium and zinc, vitamin D, etc. play important role. They have a vital bearing in RPL. Obesity, yes, all of us know whether it is a diabetes associated, PCOS associated, or obesity per se can add to the burden of RPL. Even too low body weight, not an ideal body weight, lean body, not so nourished body, not enough of muscle mass can cause problem. Of course, cigarette smoking increases DNA fragmentation index in men and even in women. It is not good because the blood supply to the ovary will not be so good. Alcohol, ionizing radiation, etc. can definitely cause problem. There are some conflicting reports about caffeine and anesthetic gases, and there is no evidence of mental stress. This many of our patients keep asking us some family problems, some mental stress, I could not sleep, is my baby going to have any problem? So mental stress does not have any bearing in the cause of RPL. Coming to the investigations, again under the same head, the anatomical causes, the TVS is to add not put everything in detail, just mention few points here. Again, practical. TVS is to assess the uterine anatomy. Of course, one TAS is that's a transabdominal scan is necessary in the beginning just to have a bird's eye view, but TVS is the one that steals your attention, and TVS will tell you about the details of the uterine anatomy, especially the presence of congenital and uterine anatomy like fusion abnormalities. 3D is definitely preferred compared compared to TVS, especially when there is a narrow difference between diagnosis like the septum, that's a deep septum, versus bicornuate uterus, where 3D gives a better picture, throws more light in support of diagnosis. Hysterosalpingography, yes, very much necessary, is one of the important investigations in the battery of uterine anomaly diagnosis. Hysteroscopy will tell us whether it is a septum or a bicornuate uterus if we have not done a 3D, or how big the septum is, the capacity of uterine cavity. We can also check the other things like the submucous fibroid, polyp, the ostia, are the ostia open, etc. Chronic endometritis may show a bald endometrial cavity, and the endometrial biopsy may be necessary when we think of the tuberculosis or chlamydia, etc., as the cause of chronic endometritis, because after treatment of tuberculosis only the woman has to proceed for the further treatment of infertility or wants to conceive on her own. Sonohysterography is another investigation that is done, and meanwhile the tubal patency also can be checked here. And after all this investigation, if you cannot make a diagnosis, then only the MRI is required. So practically in most of the cases, 99.9% of the cases, to make a diagnosis of the anatomical abnormality, MRI takes the last seat. Coming to the genetic investigation, product of carrier conception, karyotyping. What are the problems with the karyotyping, the fetal karyotyping? That is the maternal, this is I'm talking about the POC, product of conception. The problems would be the maternal tissue contamination. Chorionic villi has to be separated from the maternal tissue, and karyotyping is very expensive. Fish study is not so much recommended nowadays, and it was the test of olden days. The CGH, that is a comparative genomic hybridization, is the test of present day. It is better than the above two, and it is currently used. Next generation sequencing is gaining popularity. Parental karyotyping with the peripheral sample has to be done in following three conditions. And what are these indications? One, if there is a strong history of RPL, there is a diagnosis of pregnancy, strong diagnosis of pregnancy, and she has lost that pregnancy, and not once, it is more than twice or thrice. Number two, if the offsprings with the previous offsprings had, whether it's a present living one or non-living one, got terminated, whatever, the scan diagnosis the woman is carrying about the details of the previous pregnancies, which tell us that there was congenital abnormality. There is a confounding diagnosis of the congenital abnormality in the previous pregnancy. Two, and third is product of conception with the chromosomal testing, if they have done the testing by any of the above methods, if they have shown. And these are the three strong indications for going for peripheral karyotyping. PGD, that's preliminary diagnosis if it is an IVF pregnancy, because you can take it till blasto and take one cell and send it for the chromosomal testing. So this is a slide in nutshell. First miscarriage, actually no action is necessary unless it is clinically indicated, because this happens most of the times and it does not get repeated. So we don't have to go for the extensive investigation like chromosomal karyotyping, etc., of the maternal, paternal, or the product of conception. And she forgets and we forget, and second pregnancy happens, and that's a fine one, and that solves the matter. But what if the woman has a second miscarriage? This is again little confusion. Some people do say second and some people say three miscarriage. However you want, you can take it. In my personal practice, I make it only after the third miscarriage, whatever. So obtain the miscarriage for karyotyping. If it is aneuploidy karyotyping, it's a straightforward diagnosis. So there is no further evaluation that is required. If it is euploid, it's a problem because you have not made a diagnosis there. It's euploid and everything is fine. So the karyotyping problem is ruled out, and so you have to make another diagnosis or go further on to find the take undertake other investigation and find out why RPL has happened. But if it is an unbalanced chromosomal translocation or inversion, perform the parental karyotype and offer pre-genetic diagnosis for further pregnancy attempts. This is what I was telling in the previous slide. Coming to the autoimmune or the immunological disorders, screening for the lupus, anticoagulant, and antiphospholipid, which are the ones we have to do. We need not do all the investigations in that. It is screening of LA, antiphospholipid antibody, anti-cardiolipin antibody, anti-beta-2 glycoprotein 1, and anti-nuclear antibody. These are the 5 only. According to Sapiro, it is further reduced to only 3. What does he say? The clinical criteria of Sapiro I have told in a previous slide. Now coming to the lab, under the investigation category, I have put the lab criteria of Sapiro. He says presence of the lupus anticoagulant in the plasma. Look at the investigation. 1, it is a lupus anticoagulant. 2nd, anti-cardiolipin antibody. And 3rd is anti-beta-2 glycoprotein. These are the only 3 things he says. He does not talk about the anti-nuclear antibody, etc. So any of the above 3, these 3 which I mentioned just now, any of the above 3, if it is more than 99th percentile, or to be more familiar with that, or an easy one is a medium to high titer on more than 2 occasions. It has to be done twice. It has to be repeated only once. And if it is more than 99 percentile, that does not make the diagnosis of lab criteria of Sapporo or the diagnosis of autoimmune disorder. So more than 2 occasions, and they also have to be 3 months apart. In spite of that, both the values, if they show medium to high titer of these 3 investigation, then it fits into the diagnosis of autoimmune or the immunological disorder. Certain tests are not recommended. We hear certain hi-fi words or hi-fi investigations like testing NK cells, anti-HLA antibody testing, etc. These are the tests which have shown nothing. They have not yielded any result, never supported our fact in making the diagnosis. They don't throw any light. So don't make these investigations under your battery of tests. So these are the only 3 tests if you think in terms of autoimmune or the immunological disorders. So this is the same slide, that is Sapporo's classification 2006 in nutshell. The first part is the clinical diagnosis, which I have already mentioned to all of you. It's a thrombosis or the pregnancy morbidity. Like men, it is more common. Antiphospholipid is more common problem in women. More, it is 2:1 in the ratio. So it is, even men can have problems. That means a diagnosis in the presence of arterial or venous or a vessel thrombosis. When it comes to women, it is either thrombosis or pregnancy morbidity. I will not go into the detail because I've already mentioned, and this is also the one which I mentioned just in my previous slide. Just to put them in nutshell, I have put that ACA, LA, and beta-2 glycoprotein. So these are the investigations 12 weeks apart. That is what it says. Coming to the, what are the other investigations for thrombophilia we have to do? The platelets, clotting factor, protein CS deficiency, homocysteine level, etc. Just watch this line. The normal homocysteine level is 15 to 30 micromoles per liter. It's very common that it is much more than this. Endocrine, TSH, TPO, that is thyroid antibody and prolactin. So don't forget prolactin when she has repeated pregnancy loss. The investigations for the male factor, already said that male is also a part of all this problem. So what are the tests I'm supposed to do? The semen analysis, of course, routine, because we have to know the morphology in the semen, especially. This is a very, very important, not the forward motion, not the count, the morphology, that is very important in making the diagnosis of RPL. That is, abnormal sperm is equal to more chance of RPL. Semen culture, because infection is also one of the important causes. DNA fragmentation index, more the DNA fragmentation index, more than 30, higher the chances of abortion. For the woman, when you are suspecting infection, high vaginal swab, because bacterial vaginosis, we may be thinking in terms of, that is the swab in the fornix, urine urine culture, the endometrial tuberculosis should not be forgotten. These are the investigations not so routinely done. HbA1c, these may be supporting diagnosis, but they do not change our diagnosis, or they do not lead us to the diagnosis of RPL, because we have better investigations in each area of these. So ultimately coming to the treatment. So in spite of all this RPL, many times, so many investigations, diagnosis is made, don't quit. There is hope. So treatment of uterine anomalies, of course, all of us know removal or the cutting of the septum. If the septum is an isolated finding, this is a very, very encouraging fact. Look at that. If the uterine septum is an isolated finding, like all other things are normal, this is the only problem I have found in that woman. Male factor is normal. Her other investigations are normal, and I have found this looking at uterine septum is staring at me. So in that case, incidence of miscarriage is reduced from 85% to 10%. It helps to a very, very great extent. So remove the septum. So septoplasty or cutting of the septum is very much necessary there. So the hysteroscopic removal of the septum is strongly recommended. Didelphyic, bicornuate and unicornuate uterine correction is not at all recommended. At the maximum, you may do little lateral scratching, or the cervical incompetence part you can take care of when you're scared or when you're anticipating, in the sense once the pregnancy has been made and the NT scan is done, as soon as the NT scan is over, you can put a cervical stitch to these people. Polypectomy, hystero or laparoscopic myomectomy in suitable cases. Intramural fibroids, they need not be removed if they're smaller ones, say 2 centimeter, 3 centimeter intramural fibroids. They are definitely not going to cause problem, because they neither increase the uterine contraction nor do they put the endometrial, subendometrial blood supply into problem. Submucous distortion, or they are too submucous and they are coming in the way of vascularity of the endometrium. Intracavitary adhesions, whether it's because of chronic infection or assurements, have to be excised hysteroscopically, and all of us know that after that the woman will be on estrogen for 3 months, etc. Cervical incompetence, just a one slide on that. Cervical cerclage reduces the rate of preterm birth. All of us know emergency cerclage is beneficial if no infection or uterine contraction. Of course, it is not the one which we want to do. It is always the elective cerclage at 12 weeks. If you are anticipating problem, that is much, much better. The emergency cerclage, it does not have much good results, especially when the cervix has started giving away and the length of the cervix is becoming short, less than 2 centimeter. Vaginal progesterone, in many, many cases, when you're not very sure of the diagnosis, cervical incompetence, when the woman is ready to listen to your instructions and repeated sonographies have not shown decrease in the length of the cervix or the funneling of the internal os, probably vaginal progesterone can help you in avoiding the cervical stitch. The serial sonographic monitoring is very much necessary. 1, to know the length of the cervix. 2, more than that, the very early stage of the cervical incompetence is the funneling of the cervix, so the cavity, the amniotic cavity gets into that. So cervical funneling is very, very important to note with the transvaginal and transabdominal scan. Now, treatment of the genetic causes. Genetic counseling by especially the genetic counselor would be much, much better, who would explain all the possibilities after drawing a family tree, understand the plausibility and probability, and then counsel the parents of RPL. The gamete or embryo donation, if the problem is, chances are very high, say like autosomal dominant problems, the gamete or the embryo donation, if both the partners are affected, the embryo donation will help them. Pre-genetic diagnosis and proceed if it is an IVF pregnancy. Previous pregnancy she had, she lost them, the RPL, you don't know the exact diagnosis. Now she has been subjected to IVF treatment. Then you have formed the embryos. So take one blastomer and do the PGD and get the good embryos and transfer them into the uterine cavity. The embryo transfer, that way is better in curtailing RPL. The treatment for the antiphospholipid antibody syndrome and other thrombophilia, as I said, they all come together. Treatment part, the low dose aspirin. Some studies say 75, some say 100. They even extend up to 150 milligrams of aspirin per day. The low molecular weight heparin, that is enoxaparin, 40 units subcutaneous daily is the dose, up to 34 weeks, and success rate, some people even continue it much more than that, and I will tell in my future slides, up to 34 weeks, and success rate is up to 70% if the diagnosis is thrombophilia, as the thrombophilia is the cause. IV immunoglobulins, intralipids are all coming into the latest modalities and armamentarium of treatment. GCSF, that is granulocyte colony stimulating factor, where we give subcutaneously repeatedly when the embryo transfer has been done, before and after the embryo transfer, hoping for getting a good endometrial support. Probiotics, of course, do help a lot, and there are many studies which say explain the role of vaginal microbiome in the RPL, that is the uterine and the cervical environment. Other than the vaginal environment, they are going to make it very conducive for pregnancy. Platelet-rich plasma in the subendometrial layer, stem cell therapy are gaining lot of popularity nowadays. The steroids are not so beneficial according to many studies. So the main two pillars are, number one, low dose aspirin, number two, low molecular weight heparin. Recent meta-analysis has shown that combination of these two, this is what I was telling, aspirin plus heparin is better than aspirin alone in achieving live births in RPL cases with antiphospholipid antibody syndrome. When should I start aspirin? I should start it before she conceives. She has had 2 RPL, start aspirin, let her conceive on aspirin, nothing is going to happen. But stop that at 36 weeks, because after that anytime she may go in labor, or 1 week prior to planned delivery also is fine, because more than 3 to 4 days it's not going to act. When should I start heparin? According to certain studies previously, they used to say start at 12 weeks. Then it said that come earlier, that is as soon as you see the fetal heart, say 6 weeks, 8 weeks, can you start heparin? Now they have even extended to the left, and they say that start heparin, please start heparin as soon as the pregnancy is diagnosed. Whether it's a beta HCG or your urine pregnancy test, you made a diagnosis of pregnancy, start heparin irrespective of presence of fetal heart, because it may not even come to that stage sometimes, and by the time the woman comes, the fetal node might have appeared and the fetal cardia might stop by the time you do a scan. So I don't want to lose this pregnancy at any cost, so I'm going to start heparin much earlier, and nothing is going to happen because it is not teratogenic, and heparin is continued throughout pregnancy but should be stopped around 24 hours before the time of labor. Heparin does not cross placenta, so there is neither teratogenicity nor fetal anticoagulation. I'm not worried about the fetal bleeding, the intrauterine, intraventricular hemorrhage of fetus, etc. I'm not worried because heparin does not cross placenta. It does not require coagulation profile, so patient friendly, no, so doctor friendly. It does not need coagulation profile monitoring like we do the PTINR, etc. Unlike unfractionated heparin, where that needs coagulation profile monitoring. Coming to other endocrinological causes, please excuse me, I have come to the very last fag end of my slides. The L-thyroxine supplementation definitely will reduce the risk of miscarriage when in both clinical and subclinical hypothyroidism. Like the subclinical hypothyroidism is the woman has shown in the blood test the TSH more, but she has absolutely no symptoms. So the TSH level should be checked as soon as the diagnosis of pregnancy is made, at least at 7 to 8 weeks of pregnancy, especially with the backdrop of RPL. All the more I have to test the TSH at her first visit so that I will know whether she is a hypothyroid and that has made the RPL, or even if she's labeled as hypothyroid, is the amount of thyroxine, the dosage sufficient, and is that optimum, etc. The evidence is insufficient regarding L-thyroxine supplementation in euthyroid women. In euthyroid women with the presence of thyroid antibodies, that is not so sure. Luteal phase deficiency, there are ample evidences to show supplementation of progesterone. Progesterone has come to mainstay. Whatever is the mode of progesterone you want to give, vaginal progesterone, oral progesterone, intramuscular, subcutaneous, let us not split hair here. It says that supplementation of progesterone is must in all the cases of LPD, in all the cases of RPL. When you do not have a definite diagnosis about the cause of RPL, it is very much necessary, and in all IVF pregnancies. But recommendation for the use of HCG, that is human choriogonadotrophin, is not so ample, not so supporting. Benefit of progesterone could be explained by its immunomodulatory action. Look at that. All of us know about the two arms, that is TH1 arm and TH2 arm. TH1 is a pro-inflammatory, that's a cytokine activation responses, natural killer cells, all the inflammatory things are there, and thus the pregnancy gets lost because the maternal immune system just does not embrace pregnancy, and it just throws the pregnancy out. What does the progesterone do? It converts this pro-inflammatory TH1 into anti-inflammatory TH2 arm. So it's an anti-inflammatory response with the adding of progesterone, the addition of progesterone, and thus the pregnancy is welcomed, and the maternal and the fetal response to each other is so conducive that endometrial embryo talk is going to be very friendly, and thus the pregnancy gets accepted and continues. Polycystic ovarian syndrome, of course, metformin is there, and that's the mainstay of treatment, and that reduces the risk of pregnancy loss because it corrects all the biochemical abnormalities like hyperglycemia, hyperinsulinemia, etc. Pituitary suppression before ovulation induction could be an option in the diagnosis of PCOS when her AMH is very high, more than 10, more than 6, plus LH is so high. So these are the women where I have to give her a pre-treatment before taking her for ovulation induction, whether it is with OCP, Antag, or progesterone, whatever. Let us not talk about that, but she needs some kind of pituitary suppression. Otherwise, she's going to, even if she gets pregnant, she's going to lose this pregnancy in the first trimester because her LH is so high. Hyperhomocystinemia, I have touched upon this in my previous slides. The treatment part, coming to the treatment, would be folic acid, as I've already told, because that converts the homocysteine to the active form of the folate, the tetrahydrofolate, and further on. The multivitamins, antioxidants are equally helpful. Hyperprolactinemia. Oh yes, prolactin is one of the culprits, which is the important cause many times we ignore, or we might have forgotten in making the diagnosis of hyperprolactinemia. It plays all the more role when the woman is anovulatory. So the dopamine agonist like cabergoline is the treatment. I have not gone into the detail, the treatment schedule, how long it should be taken, etc., because RPL itself is very, very vast topic. Treatment of the male factor, already told, stop smoking, treat the cause, that's all. Stop alcohol, body weight, yes, of course, it's very, very important. The exercise plays a very important role so that the abnormal sperms are gone, spermatogenesis is improved, get a good sperms, the blood supply to the testicles are increased, etc. The job, the person has to avoid the thermal exposure like a factory, that's a thermal factory, etc. Broad spectrum antibiotic, if your the semen culture shows infection, treat with the proper antibiotics. Antioxidants help to reduce the DNA fragmentation index. I studied recently, and yesterday it was accepted in ISHRE about the antioxidants, role of antioxidants and inacetols in PCOS. Meanwhile, and similarly, the antioxidants do help to reduce the male problem also, like they reduce the DNA fragmentation index. The infection, yes, the bacterial vaginosis is either with oral metronidazole, age-old, traditional, common, easily available and cheap. Clindamycin also is taking importance in the treatment of bacterial vaginosis. UTI, get the culture done, treat appropriately. Tuberculosis, anti-tuberculous treatment is the treatment. So coming to my last slide, conclusion would be RPL is a professionally challenging situation to the treating physician and psychologically challenging situation to the patient, as the diagnosis, etiology, investigation and treatment all are not at all so clear. The recurrence is difficult for the doctor to counsel. It's very difficult for us to explain, in spite of doing so many things, why it happened. This will be the straightforward, plain question thrown on our face. So the recurrence is very difficult for the doctor to counsel and so traumatizing for the couple to accept. But end point of all the agony, carrying home finally a healthy term newborn baby, is the ultimate joy to all of us, isn't it? So God grant me the serenity to accept the things I cannot change. Certain times I really cannot change. The courage to change the things I can, and the wisdom to know the difference. Thank you all for your patient hearing. Thank you. I'm going to stop here.
Yes, thank you very much, ma'am. First of all, I want to convey my sincere apology due to some technical error. First, I could not control the platform.
Yeah, that's fine.
Secondly, thank you very much for this very nice and informative talk regarding the recurrent pregnancy loss. As we understood that there are many etiologies are involved in this problem. And meanwhile, I received my few questions. So if you allow me, then I can.
Yeah, why not? Why not?
Yes, ma'am. So, ma'am, in case of my first question is in case of recurrent pregnancy loss in the old patient, means some delayed age. So, what will be your first approach to treat that?
The first thing is I'm going to counsel them that this may, as I have already told in my slides, then don't lose hope. You may get pregnant. Second is I will get her important investigations after taking history. I'll come to know certain things where the problem is, like whether it's I'll put a scan machine that's a transvaginal probe, it's a uterine problem, or history wise I will know whether it's a immunological problem, etc. So I'll do few investigations which are relevant to her, come to a diagnosis, again counsel them, sit and talk to them. This is the probability of pregnancy. If everything is bad, if there's a lot of problems, if there are not correctable problems, like the male factor, the semen abnormality is so much, or the woman has lot of problems, or the age is so much, you have not mentioned the age, say about she's 45, the chances of losing pregnancy is very high. So I will counsel her to go for a third party reproduction. But that would be the end option. That would be the last option. This is just to summarize.
Okay, madam. And ma'am, what is your practical experience on that? Is there any difference between diagnosing the patient in case of first pregnancy or in case of that RPM in subsequent pregnancy?
Yes, I have told already in my slides. In the first pregnancy, the diagnosis is different, the treatment is different. In the first trimester, especially till 8 weeks of pregnancy, about 2/3 of that is because of the chromosomal abnormality. If she has crossed 8 weeks, if I've seen the fetal heart, I am much better. I am relieved to a great extent that the problem is much less. Once the fetal heart appears, the chances of abortion is going to reduce to a very great extent. The diagnosis would be in first trimester pregnancy. It is the very early pregnancy would be the chromosomal abnormality, and later on, that is 8 weeks plus, all that I have to think in terms of thrombophilia, especially if it is RPL. These are the two common causes. When I come to the second trimester, the whole diagnosis will change. It is most of the times not because of these two. If these were the two, it would have gone, the pregnancy would have got terminated spontaneously long back. If she has crossed crossed 12 weeks, that means it is not because of these two. Most of the times it is either because of the cervical incompetence or other uterine abnormalities, like as I have told, the unification problems, that's the fusion abnormalities in the uterus. The history, that's what I said, the history itself gives us most of the times the diagnosis, and then the clinical examination, and then the investigation. So by the time we come to the investigation, most of the times our diagnosis is made.
Okay, madam. And another thing, ma'am, as you mentioned that PCOS also have a role in this RPM. So in that case, it has been seen that PCOS is a lifelong problem sometimes.
Yes.
So how do you treat? Means you will first treat the PCOS, then you will go for some other.
Yeah. See, the first thing is again counseling. Tell her, put it in her mind. If you just treat, just give a prescription, she'll take the tablets for 3 months. Say you would have put her on metformin, inositols, antioxidants for 3 months, and then she'll throw your prescription. It should come to her mind that this problem is going to be with me lifelong, and I have to carry on with this problem. And on top of that, I have to get pregnant. Even if she gets pregnant, the chances of recurrent pregnancy loss is much more, because that pregnancy is not going to be so good. In the backdrop of hyperinsulinemia and hyperglycemia, that pregnancy is not a quality pregnancy. So the chances of abortion is much more. All this should be told to her, that should come to her mind. In that case only, she'll take care of her diet, exercise, reduce her weight by 10%, etc. Because 2/3 of PCOS are obese PCS. Obesity comes along with PCOS in most of the cases. So she has to reduce her weight by at least 10%, which you and I cannot do, and she only has to do. Even the husband or family members cannot do anything. She has to take care of her diet and exercise. So the counseling plays a very important role. The second thing is the diagnosis of PCS and monitoring her PCS. That is, when you scan her, you see how the follicles are, how your treatment is going to start, etc. And the third thing is, before you start the proper treatment like ovulation, induction, etc. I'm just talking this in the backdrop that I am an IVF specialist. So when the patient comes to me, I put them on 3 months of metformin with her lab parameters being very high, like the AFC is very high, more than 20 of follicles on both the sides, with hirsutism, with the LH is very high, AMH more than 5-6. All these women I do, when I make a diagnosis of hyperglycemia or HbA1c is so high, I do put them on metformin. So I will not I will tell her, you continue treatment from your side, like the taking part of weight, like the diet, exercise, etc. And I will continue my metformin. Let both of us work together, and at the end of 3 months, I will start her on proper ovulogens.
And another thing, ma'am, I want to know that if it is means confirmed PCOS related RPM, and would you like to prefer myoinositol supplement also?
I do start them on myoinositol also, because I don't leave any stone unturned. I start them. If I made a diagnosis of PCOS, yes, I do give them metformin plus myoinositol. Myoinositol is more of a food product, or it's like a nutrient I tell them to take, but I do not continue the myoinositol once the pregnancy is made. But metformin I will continue even after the diagnosis of pregnancy is made, because I want her blood sugar to be quite normal when she is entered into pregnancy journey.
And my last question is, if it is found that it is related to some autoimmune, so in that case, what will be your approach?
I have already told in my slides that my approach would be, it is a combined therapy of aspirin with heparin. I start them on low. Once the diagnosis is made, I put them on aspirin, that is 75. I put them on 75 milligram per day of aspirin plus everyday low molecular weight heparin. Why I do put them on 40 units low molecular weight heparin is because it has shown in many studies that it reduces the incidence of RPL to more than 40 to 50%. This is only in cases of made diagnosis of thrombosis, thrombophilia cases. One, and second thing is heparin is non-teratogenic, and 3, LMW, that is a low molecular weight heparin, need not be monitored with the lab parameters. It is so patient friendly, so I start them on low molecular weight heparin.
Okay, madam. Madam, another one question I can see asked by Dr. Avadevi. The question is one pregnancy loss at 9 weeks. Any investigation needed? Patient is very anxious.
Most of the times, the routine investigation would suffice, like the TSH, the transvaginal scan, and if you can get the details of the previous pregnancy, like whether the heartbeat had appeared, not appeared at 8 weeks, etc. But most of the times, if everything is normal, nothing is staring at you, like hypothyroidism is not there, PCOS is not there, and everything with the family history of absolutely no problem, etc. One pregnancy is quite okay, because most of the time that is not going to repeat. RPL is not going to repeat most of the times. As I've already told in my slides, they do stand a chance of 60% of good hope having a good live birth pregnancy in spite of 3 RPLs. That is a 3 pregnancy losses. Also, they do have a 50 to 60% chance of having a good baby subsequently. So with one pregnancy loss, it's just the counseling if everything is normal. But if you feel that there is already some problem, like the diagnosis, their woman is hypothyroid, you have to treat hypothyroid. If you check the routine investigation, if you find some problem like urine culture shows UTI, treat that. The husband has problem, you treat them. PCOS, you tell her to reduce weight. All these things you can do without much effort and cost. I hope I'm
Okay,
clear.
yes, ma'am. And madam, I could not get any other question. And so, if you allow me, then we can close this session today.
Yeah.
And
I
last thing, thank you very much, ma'am. Thank you for your valuable time in our platform and for this nice talk and informative talk. So we look forward in future also from you such kind of session.
fine.
So thank you very much, ma'am.
Yes.
Thank you. Have a good day, ma'am.
Yeah. Thank you so much. Thanks for the platform. Thanks for the opportunity. I hope I was of some use. Thank you, Ms. Dr. Suman. Thank you, Krishna Patil. And thank you, Shield Pharma. More than anything, thank you, participants, for logging in for your quality time. I hope that I was of some use to you all. Thank you. Bye.
Thank you, madam. Thank you very
Thank you,
much.
ma'am.
Bye.
Thank you.
Bye. Yeah. Bye. I'm leaving.